Hi everyone. Good afternoon for those joining from the East Coast, and good morning for everybody joining from the West. And thank you so much for joining us today. I see that folks are still popcorning in, so we'll give another 30 seconds and then we will get started. Okay, I think we have a lot of folks joining in still, but we can quickly get started and people can settle in as we go forward. So again, thank you so much for joining and happy November. So pleased to see you here. I am Srija. I'm the Senior Project Manager at the Canadian Institute for Social Prescribing, and I just really wanted to welcome you all today to our very, very special webinar, Community Roots National Impact, a Social Prescribing Celebration. Next slide, please. I would like to start by acknowledging that our work takes place across vast and diverse lands through Northern Turtle Island, the territories of countless Indigenous nations of First Nations, Métis, and Inuit people who have cared for these lands, water, and resources since time immemorial. Throughout history and into today, Indigenous people have nurtured holistic approaches to health and well-being, understanding that being well encompasses physical, mental, emotional, and spiritual dimensions. And rooted in profound respect for the interconnectedness of all living beings, Indigenous practices recognize the inseparable link between human health, the health of the land, and the health of the community. And as we work, learn, and live on this land, we are
Sarija, I think you muted yourself. Sarija, we can't hear you. Can you ask Grace to close her laptop and you turn on your microphone for us?
Yes, my Zoom just died. Yeah.
Can you hear me okay now?
Yep, you can go ahead. Thank you.
Nicole, can you confirm that you are able to hear me?
Yep, I can hear you.
Nicole, can you confirm if you can hear me or not?
Yes, I can hear you, Sarija.
Thank you so much. We just wanted to let you know that a lot of our panelists are joining from the same room today, which is a very rare event, but it's very exciting. But at the same time, it comes with a lot of technological limitations. So we are navigating that, and my apologies for that tech challenges. And I'm so grateful that you are all patient with us while we figure that out.
Progress.
I Nicole, if you can move to the next slide, please. So again, just to reiterate that a lot of you were in our social prescribing conference last year. That was in Toronto, and it's a wherever we go, we hear about that a lot, and it feels like it was a moment we still look back on with so much warmth, and the energy in that room was just incredible. We had so much to learn from all of you, so much to learn from all the provinces, all the different types of projects that's happening across Canada. And also, we learned a lot from our international partners too. That was really, really a moment of celebration. And we wanted to keep up with that momentum. We wanted to make sure that we don't lose that momentum because there's so much happening across the country and internationally. So we wanted to bring folks together again while we're not able to do something in person this year, but we're very, very happy that we are able to come together virtually for this engagement together today. And today's engagement will really be a moment to celebrate with how far we have come. We will take some time to recognize some of the wonderful accomplishments that we have seen across the country, whether that is building relationship with the different sectors, building connection with the communities, and also recognize some specific efforts that was made that really led the success that we have seen in the last couple of months. And we do have a couple of resources that we wanted to share with you. So stay with us till the end of it, so we can really share some of those resources with you. I wanted to also start with a little bit of a quick overview of the Canadian Institute for Social Prescribing, or what we call CIS. CIS is a national collaborative that is anchored by the Canadian Red Cross. And at CIS, we bring together a diverse network of Canadian and international voluntary sector partners, health practitioners, researchers, academics, systems leaders, and funders, and also the people themselves and practices. So we can really foster knowledge, we can connect people and convene the work that's happening across Canada, build evidence, and influence policies to strengthen health and community care systems. And these are just the 4 pillars of work that we do. And through these four pillars, we work to support social prescribing initiatives across the country, so we can empower communities and empower individuals to take better control of their own health and well-being, and really create a sustainable healthcare system moving forward. You can find more information about the work that we do on our website, and my colleague Winnie will share the link to our website in the chat box. So feel free to visit our website when you have an opportunity. Next slide, please. Oh, actually, before we go to the next slide, I do have a couple of housekeeping items. This webinar will be recorded and shared, and we will be hearing from some of our recent remarkable social prescribing accomplishments in the landscape. We'll be celebrating the Impact Award that we're giving out this year, and also launch a couple of resources. We do have a pretty packed agenda, so we won't be able to address any raised hand in the conversation today. So if you have any question for any of our panelists, we request that you use the Q&A function in Zoom. You can pop in your question in the Q&A, and our panelists will directly answer your questions through that function. If we cannot address any of those questions, we will try to address them offline and send you a follow-up afterwards. We might not also be able to address any of the questions that comes to the chat box. So really encourage that you use the Q&A for any question. So I will now be handing over to Beth Mansell, who will be our moderator for the day. Beth is the social prescribing project manager at the Health Aging Alberta, and she has been leading a lot of excellent work, and she will be moderating our wonderful conversation today. So over to you, Beth.
Perfect. Thank you so much, Shrija. It's great to see such a good turnout today for this event. So as Shrija mentioned, my name is Beth. I work in Alberta. I'm located in Edmonton, and I'm really grateful to have been involved in the social prescribing work here for the past 3 years. And so today we're going to be hearing about important work coming from 4 great speakers from across the globe, actually, which is really cool to see. So first up, we have Judy O'Keefe, who is the project coordinator at Seniors NL in Newfoundland, and has been a fantastic lead of integrating social prescribing for older adults in the province through cross-sector collaboration. We have Dr. Grace Park, who is the lead clinical research and former medical director of home and community care with Fraser Health in the Lower Mainland in BC. We have Wendy Johnston, Director of Programs and Innovation at the Family Caregivers of British Columbia, has been a fantastic leader of caregiver support and is now heading a caregiver social prescribing pilot in the province. And then we also have Charlotte Osborne Ford, who is the Chief Executive Officer of the National Academy for Social Prescribing in the UK, and has been leading social prescribing nationally there and supporting Canada in advancing our work through shared learning. So I'm going to pass it over to Judy to start. Go ahead, Judy.
Okay, well, thank you very much for having me. So as Beth mentioned, I come from an organization called Seniors NL in the province of Newfoundland and Labrador. And we've been involved in social prescribing for the last 2 years. And I've been with the project for the last year. And I just want to talk briefly about some of our accomplishments, but also some of the reasons, some of the enablers and barriers that are affecting the work that we do. So Newfoundland's experience really shows that social prescribing can move from concept to system level practice, really when community and health come together as equal collaborators. The effort has really centered on building a model that complements primary care or primary health care, strengthening community capacity, and then using evidence to guide our decisions. So learning as we go, I would say. So our update really highlights how social prescribing has become embedded across the province and really the key conditions that have enabled us to scale so quickly. Next slide. So just excuse me for a second. I can't see my slide. Let's move it. Okay, so Newfoundland's model really works because it joins, two key strengths: primary care as the access point, where those family care teams create consistent referral pathways and a clinical home for social prescribing. But also, the other half of this relationship are the community organizations like Seniors and Now, who act as the delivery partners, where they anchor the work and ensure that social supports are trusted, accessible, and province-wide. So that dual foundation really allows older adults to be identified early, referred quickly, and then supported through resources that can reduce their isolation and strengthen their wellness and continuity of care. Next slide. So this is really the why of how we've been able to advance quickly in the province. And we've been able to really move fast because several conditions really aligned at the same time within the province. And I think these are kind of core to, our success. First of all, when we talk about structural readiness, Newfoundland, as many people may have heard, just became kind of known for being the oldest province in the country. So we now officially wear the title of having 25% of our population are over the age of 65. And I was saying in a room earlier that also 40% of our population is over 50. So, we know that we have a population that requires this level of support because there's rising complexity and creates an urgency for more upstream community-centered approaches. The other thing is that Newfoundland as a province a few years ago was involved in a major system transformation and analysis. And so Health Accord NL really in their report to the province about changing the health system really talked about mandated prevention and community integration and creating and giving permission really to the system to innovate. And social prescribing was seen as a social innovation. The other component here that our recipe within the success has been really primary care reform was already underway. So family care teams in the province were forming across all of the province, really giving social prescribing an operational home. So, we are co-located and embedded, I would say integrated even so, within those family care teams. So providers were already kind of redesigning the workflows and making the integration of link workers really a natural extension. So they already knew that there was a gap around social prescribing, and then by bringing us together, co-located in those family care teams, then they really could work very closely as partners with those link workers. So I say to folks that I don't think any of us really know who's working on what team because we all work together in those sites. And so then the other part of I would say the recipe for success here has been the community capacity provincial reach. So Seniors NL is a province-wide organization supporting older adults where we provide information and referral services, resource management, and outreach. And it seemed really important and really aligned well that social prescribing became, its fourth pillar. So it already had, through the organization, a significant degree of credibility with older adults. And we had built relationships over decades with hundreds of community organizations and community senior serving organizations. So naturally became that, enabler and connector of services. The other component that has been important here has been our governance table. we have an advisory committee which includes a number of organizations from government, from system transformation, from primary care to patient partners and community organizations. So it's a very robust advisory table who really lean into their experience in terms of the organizations that they're representing, but really have a good understanding of social prescribing. So at that table, we're really able to ensure timely decisions, rapid problem solving, and alignment across the zones. And as well, another enabler has been our evaluation system. So early evaluation has really allowed like rapid cycle adjustments, and that builds confidence in the clinical team. So the clinical teams could really say, this works, this doesn't work, and then we made changes as a result. And then they could see how their ideas and innovations were integrated into the work that we were doing. So those combined factors really shortened our implementation time and increased adoption across the regions. Go to the next slide. So I've talked a little bit about this, the primary care integration, but I really think this is most important for us, that embedding the link workers in primary care has been the single strongest enabler. And it really changed social prescribing from an external referral to a routine part of clinical practice, because no longer were we sending, I worked in healthcare for many years, and you're sending referrals out to organizations. Sometimes you don't know if the referral is accepted, what happens after. So having the link worker embedded into those clinical workflows has made a huge difference. And how it works in Newfoundland, there's really a warm handoff kind of allows the providers to connect to patients immediately to support. So if you're the family physician and you're talking to your patient, there's a significant degree of trust there, and you're making recommendations around a service. What happens in our sites is that sometimes we're able to say, oh, come meet Judy. She's a link worker and she's going to help get you connected to those services. So it's just, it kind of builds on those relationships. There is also shared care planning, really ensuring that those social needs are addressed alongside the clinical issues. So it's part of the person's plan of care. Social prescribing is embedded into that. And we also have regular team huddles and interprofessional collaboration. So we ensure that the information flows and follow this consistent. So as I mentioned, it's really that integration where the link workers are part of the team. They're able to offer suggestions and solutions right at the table at the same time when those discussions are being had. So it really reduces fragmentation and helps providers feel that they have a reliable partner in looking at the social determinants of health. Next slide. So the core design features here look and feel consistent across all sites because the foundational elements have been really intentionally standardized. And these are our elements. So we have embedded link workers with very clear roles and scopes. All of the team is very familiar with their competency profile, who they are, what the role description is. So it looks alike across our teams. There are co-designed workflows that really reflect the realities of each team. So how work happens, how patients are referred, what services are enabled and available in different areas. We have standardized referral pathways, so providers know what to expect. It's embedded into the EMR or the electronic medical record. The providers also are very familiar with our wellness planning, and we provide information back to the providers about that connection. So whether the person was able to be involved in a particular service, whether we're continuing to work on other parts of the plan with them. So the community supports is really integrated into the care plan, but it really closes the loop on social needs. And that consistency has built trust and accelerated speed. Next slide. So when we consider kind of integration across the system, where we're going right now in the province is really looking to integrate and expand beyond primary care as we've been able to demonstrate the value of social prescribing. So in the last 6-8 months, actually, because we're very new at this, we've been able to spread across to what I would say naturally aligning services. So like specialty clinics, so our home dementia program, geriatric medicine, our community health nurses, A lot of the senior serving kind of groups, public health, mental health and addictions, home care, they're all referral sources. We've also managed to integrate within community-based family physicians as they are naturally affiliated with our family care teams. So those new partnerships are occurring, and we're also now looking at extension to community paramedicine and even some of our senior-friendly care acute hospital sites. So again, we're looking at what are those kind of ripples that we can create because they're already part of that circle of care. So it shows the model is adaptable and scalable really across all aspects of the system. Next slide. And I'm almost close to the end here now. I talked a little bit already about governance and evaluation, so I'm not going to go too much into that here. But I do want to say that really the patient partner involvement has kept that work grounded in lived experience. And that's also been something that's been a huge enabler for us. Having folks with lived experience really speak about what their needs are, what's worked, what hasn't worked. But we also have community partners at the table. And so the way we describe our work is really we're doing that individual support and clinical work, but we're also doing the community development work. So as we're out in communities, understanding where needs may be missed because there's gaps, we're working with municipalities, we're working with community organizations to look at where we can build out services to better meet the needs of the older adults that we're referring. So I think that as well has been a really big part of our success. We've also developed common evaluation indicators. So we're looking at process outcomes and also throughput. So we're asking family care teams, this is meant for you, what's working, what's not working. How do we make this better? How do we make referrals easier? We're asking our link workers, what's been your experience? So really like leaning into that implementation science work. But we're also talking to the people that we've been able to support to say, how has this made a difference in your life? We're looking at impact on primary care, impact on emergency room. We're looking at, impact on loneliness. So pre and post intervention scales, that sort of thing. So really standardizing our evaluation. And the last slide for me. So I think we've really been able to achieve progress because social prescribing has been established across our family care teams with a very strong provider uptake. Where most of our providers have made a social prescribing referral, and I think that's a good indication of success. We've been able to expand to both specialty and acute care pathways. Again, we're at the beginning in some, but every day we're having people reach out to us and ask if they can become a part of it. And so that's a lot of the work that I do is talking to groups about how we can bridge social prescribing to the work that they're already doing and informing and educating their teams about that. So engagement from our providers continues to grow, and our shared evaluation framework is really scaling. And I think based on that, then our province is really well positioned to advance a fully integrated evidence-informed model. So we're not at sustainability yet, but I think by virtue of the fact that we've been able to scale this or spread it out to so many different referral sources, and we've had such impact that in a lot of communities, we've had a lot more conversation, and we're learning about what works and what doesn't work. And thank you very much for listening.
Awesome. Thank you so much, Judy. That was a really great presentation. There's a lot of really good, exciting work happening in Newfoundland and Labrador. There's a few questions in the chat, but I know that we don't necessarily have time. So maybe if we do end up finishing our agenda early, we can come back to the questions in the chat. A lot around evaluation and outcomes. And so to those that ask the questions, I'm sure Judy would also be happy to connect with you offline as well and can share her contact information too. So I'm going to pass things over now to Kobisha, who's going to share a little bit more about the asset mapping toolkit that's been developed. So over to you, Kobisha.
Thanks so much, Beth. Hi, everyone. My name is Kobisha. I am a current Master's of Public Health student at the Dalai Lama School of Public Health at the University of Toronto. And it is a pleasure to join you today as we launch CISP's National Asset Mapping Guide for Social Prescribing. So the purpose of this guide is to provide a practical toolkit for planning and carrying out community asset mapping in order to inform social prescribing as a whole. And so we know that a key aspect of social prescribing really relies on clear, up-to-date knowledge of what supports exist locally and within the community. And asset mapping can really be the answer to creating a living resource that evolves alongside communities and can be continuously updated, shared, and built upon in future iterations. When used effectively, asset mapping can really strengthen and provide a holistic community-led approach to social prescribing. And this guide really helps to provide tools to help identify these community asset supports, organize them in a practical format, and to ensure that they reflect what communities themselves are describing and considering as assets that are available locally. This guide will help to support more effective referrals, foster collaboration across the sectors, and inform planning and decision making to help ensure that social prescribing really remains grounded in the strengths and priorities of the communities. So as you can see, from what we have here, we have put together this guide in order to create actionable steps, key considerations, as well as key communication and facilitation resources that can really be intended to use towards asset mapping that can inform social prescribing. And so this CISP community asset mapping guide that we built here is really intended for a number of different users. It's aimed at supporting link workers, healthcare providers, community organizations, even policymakers, funders, and especially community members who are working to strengthen social prescribing within their communities across Canada. The guide is now available on the CISP resources page, and the link has been shared as well in the webinar chat, and really looks at developing and beginning right from the early preparation all the way to actually identifying and connecting individuals to these community assets that can really serve as social prescriptions within a formal social prescribing program. This guide represents months of partnership, learning, and co-design, and we're excited to be able to share it with you here today. I had the privilege of being able to work in collaboration with CISP over the summer to lead the writing of this guide, but this guide was also shaped through continuous guidance from the CISP staff team, as well as the ongoing consultation with our provincial implementation leads across the country. And so I want to make sure to thank those individuals and those organizations as well. So thank you to Healthy Aging Alberta, Manitoba Association of Senior Communities, Newfoundland and Labrador Health Services, United Way British Columbia, as well as Ontario's Alliance for Healthier Communities for their insights and resources that really supported the development of this guide. As well within this guide, you can see in the slide here as well, we've included case studies for successful asset mapping that have led to actionable social prescribing programs. And so I want to thank Seniors NL, the SEED program at the St. Michael's Academic Family Health Team, and Healthy Aging Alberta for their time and feature in this guide to really showcase and demonstrate successful asset mapping that has led to social prescribing. These insights and their practical experience is really key to that nationwide consultation that we were able to put together in order to ground this guide in real world practice. We really look forward to seeing how communities and organizations really use this resource in practice and how it can support the future growth of social prescribing across Canada as a whole, and how it may continue to evolve across future iterations. Thank you so much, and I look forward to seeing the rest of the webinar.
That's great. Thank you so much, Kobisha. It's really exciting to have this guide as part of our kind of resource toolkit, and I'm hopeful that other folks from across the country will be able to use it in their ongoing social prescribing work. Hey, the next part of our agenda is actually exciting. We have some awards that we're giving out. So you might remember if you were at the conference last year that we were able to give out these awards in person, and this year we're doing it virtually. So I'm going to start with the Social Prescribing Connector Award, and this award is recognizing an individual or team who's made a significant impact on people and communities as a social prescribing connector, link worker, advisor, or navigator. And so our first award is going to Courtney Bauman with the Woolwich Community Health Center. So I don't know if you can do like a virtual clap or something. Congratulations to Courtney. She's known for her compassion, humility, and person-centered approach, embodying the very heart of social prescribing. Courtney has made a remarkable impact by supporting clients with complex needs, from coordinating housing, transportation, and financial supports to helping individuals navigate food insecurity, case management, and digital access. Her advocacy has changed lives, including helping isolated older adults regain independence, mobility, and connection through the simple but transformative act of securing the supports they need. So once again, congratulations to Courtney. We have a second winner in this category as well. So Heather Beaumont from the town of Halton Hills. Heather is a visionary recreation supervisor at the Hillsview Active Living Senior Center, where she's redefined how seniors access community-based supports. She pioneered one of the region's earliest social prescribing initiatives, building partnerships with primary care, creating a prescription referral pad, and mobilizing volunteers to deliver more than 70 programs that reduce isolation and enhance well-being. Her leadership has connected hundreds of older adults to meaningful social, emotional, and practical supports, setting a powerful example of compassionate, community-driven care. Once again, congratulations to Heather. So our next category of awards is the Social Prescribing Innovation Award. And again, we have 2 innovators that will receive this award. And this is really recognizing an organization or program that's demonstrated exceptional innovation in social prescribing through unique, out-of-the-box creative partnerships, knowledge sharing, and novel approaches that have significantly impacted health and well-being in their community. So our first award in this category goes to the Guelph Community Health Center. They've developed a truly innovative approach to increasing food access and strengthening community connection through equity-focused, dignity-based programming. Their Seed Market Greens prescription initiative reimagines how primary care and community supports can work together to reduce barriers and improve health outcomes for people experiencing food insecurity. This model has set a powerful example of community-led, socially grounded innovation that is transformative in how holistic care is delivered. Congratulations to the Guelph Community Health Center. And finally, in this category, we also have the True Manger dans le Centre Sud. My French is not very good, so hopefully I pronounced that correctly. They have introduced a creative and community-driven model that strengthens food security, social connection, and access to culturally relevant supports for residents in the Centre Sud region. Their innovative approach brings together local partners, tailored resources, and neighborhood-based engagement to address food insecurity in ways that honor dignity, culture, and community belonging. This model has inspired new collaborations and demonstrated how localized, equity-centered innovation can meaningfully improve health and well-being. Thank you to all of the nominees and the recipients so far. Your work is a powerful reminder of how connection, creativity, and community leadership shape the heart of social prescribing. We'll have a few more awards to present later in the agenda as well. For now, I'm going to pass it over to Dr. Grace Park. And once Grace is done, Wendy will also start her presentation as well. So over to you, Grace and Wendy.
Thanks, Beth. Hello, everyone. Great to see so many people from British Columbia. Good morning to you. It's the afternoon here. I wanted to give you an update of what's going on in BC. So I'll have the next slide, please. So we have been very fortunate to have had government support for social prescribing for a number of years now. So we had our demonstration project back in 2019, where we started with 19 community connectors. And we've had increased funding now, and we're building up to 100 community connectors spread throughout the whole province. And the province is a large area, many, many communities, both urban and a lot in the rural communities. So there was a real need to develop the infrastructure, the governance structure, as well as processes to be able to enable our work. So on the United Way side in the community, so we've got the Director of Healthy Aging, Bobby Simons, that many of you know. She provides a strategic direction, provincial lens, as well as national lens, and is the main liaison with the Ministry of Health. And she also ensures that social prescribing fits with the other healthy aging programs that exist under United Way. And then beneath that, we also have Prab Sandhu, who is a new appointed person recently, healthcare systems and community specialist. And she's the portfolio lead for social prescribing for the province. And she is responsible for cross-regional coordination across different health authority, different communities throughout the province, and oversees the community connectors education and watches for emerging trends and needs that need to be dealt with. And we also have 6 healthy aging specialists, and these are community specialists who are closest on the ground with the social prescribing program. They work very locally with the community connectors. They support the local community of practice. They strengthen the community partnerships with local resources and networks. And then we also have healthy aging managers, and these people are working closely with the community of practices, as well as the other community organizations. They build community and external partnerships, and they liaise with the local health authorities. So there's a lot of work going on in the community, but with the added bodies on the ground now and with support, we're ensuring that the community connectors have the support and working toward their goal of working with their older adults that are referred to them, but also working with the community organizations to build their assets where they're working. So I'll be talking about the health system infrastructure in a minute, but I wanted to go to the next slide and talk to you a little bit about something exciting that's been happening with us in the Lower Mainland. So Vancouver Art Gallery has been very interested in social prescribing, and they actually have a program called Art in Wellness Lab. And that programming really addresses the need for mental health support and well-being support, and trying to reach out to the community and provide the arts for those that are not currently using that. They've partnered with the Park RX program, and health practitioners who've signed up with that program can write a prescription, and the prescription can be used at the art gallery as a pass to come in for an older adult and their caregiver or their friend. And they can come in and do programs that are already there, or just peruse the gallery and take advantage of what's available there. And this is a picture of the Emily Carr exhibit, which is beautiful. And I was just there recently, and this programming allows people to come in and actually go with a guide to experience each of the paintings and really transform to nature. And even though they're indoors, they can actually be part of nature. And this is all behind, that's the idea behind the Park RX program, increasing the accessibility of nature for our well-being. And so this is an exciting project led by Paula Toledo, who's on the call today, I think. And we've been meeting with Paula and with the community connectors in Fraser Health to set up a pilot program to see how we can make the arts available for the socially challenged and the people that our community connectors are working with in the Fraser Health region. And I'll take the next slide. And then in the health system, as we scale and spread, as you know, our demonstration project was mostly in the Fraser Health region, but there are 4 other regional health authorities in the province, and each of the health authorities have their own infrastructure, their own workflow and ways of
It looks like Grace might have frozen. Wendy, I'm wondering, while we wait for Grace to come back, I don't know if you wanted to start maybe with your part of the presentation. We can maybe come back to Grace's slides after.
Sure, that's fine. Absolutely.
I'm not sure. Perfect. There we go.
Okay. Sorry, Grace. I'm sure you'll be back. Good morning, good afternoon, everyone. I'm Wendy Johnstone from Family Caregivers of BC. And I'm joining you today from the unceded territories of the Comox First Nations up here in the Comox Valley. I work at Family Caregivers of BC, and we have spent nearly a decade learning, testing, failing, adapting, succeeding, evolving, and slowly building a caregiver-focused social prescribing model grounded in lived experience and system partnerships. So I've just put up a little a slide about our organization. I want to mention that we're one of 7 caregiver support organizations across Canada. And really, in particular, over the last couple of years, we've been working on a national collaborative for our highlighting caregivers across the country. We are a 100% dedicated to unpaid family and friend caregivers. And of course, we're home of Caregiver RX, which is our innovative model that's designed to make healthcare systems caregiver friendly. And I just wanted to mention that nothing we built happened quickly. In fact, it some days feels like it's moving like molasses, and other days we have other lightning speed advances. Nothing happens in isolation in the work that we do, and nothing happens without collaboration. So next slide, please. I had to choose to talk about one tiny part of our work. And if anyone has questions about our evaluation, about our caregiver support, wraparound supports, I'm really happy to connect on that at a different time. But I really wanted to talk about how we built our community-based social prescribing program over the last 10 years. I thought this would be the most impactful. So why did we start? As we know, even though there's been some really lovely historical changes around making caregivers more visible across the country, caregivers still remain the invisible backbone of our healthcare system. And so we saw patterns. Caregivers don't recognize themselves as caregivers. Providers aren't always equipped to identify them. And generally, caregivers ask for help too late and often in a crisis. So when we launched our work in 2016, before social prescribing was even language we used, our goal was really simple. It was to move caregivers from invisible to visible. And from a healthcare provider lens, it was to identify them. When caregivers were, unsure of what to do, to ensure that they could be referred into support. When they often felt excluded, was really to work on some systemic changes to engage them and bring them in as part of the care teams. Next slide, please. So our basic pathway is caregiver identification, and that comes from a caregiver, identifying themselves to the healthcare provider or social connector, or the healthcare provider asking, are you supporting someone at home or in the community? Referral, I'll get to the 4 different methods in which we have referrals, but it's either our prescription pad, consent referral, or an embedded tool systemically. And then support comes into Family Caregivers of BC, where that caregiver needs are assessed, and we're moving to a more standardized tool. And they are connected to what's locally available in their community, as well as our provincial support, so that they have this access to a real wraparound support wherever they are across the province. Next slide. So we have been a story of 10 years. And our very first referral tool was called a 10-second handoff from a provider who said, if you can give me a way to support a caregiver in 10 seconds, I'll do it. And so what did we learn from that? We learned that if it's not fast, it won't be used. If it disrupts workflow too much, it won't be used. If it's complicated, it won't be used. And that caregiver identification is critical to the success of any referral pathway. And co-design is the only way to build things that last. And so in 2016, we worked on the caregiver prescription pad. And then in 2018, we had a really interesting feedback from caregivers through one of our PDS cycles. And what they said was, I'm exhausted and I don't always want one more thing to do to have to make a call. And so we then took our Caregiver RX referral and we turned it into a caregiver consent and referral form. The other thing that we were really understanding at this time is that the system was really only built for patients and healthcare providers. And we were thinking, how do we move into triadic care? How do we somehow bring the caregiver into that care team relationship? And the key way for that is for caregivers to be seen and treated as clients, not extensions of the patient, that they have their own unique goals, their own unique challenges. Caregiving doesn't happen in isolation of life. And we have a saying at Family Caregivers of BC, if you know one caregiver, you know one caregiver. So we created our caregiver consent and referral form, which really formally recognized caregivers as individuals with their own trajectory. And we continued working upstream to systemically embed caregiver referrals. And so in 2018, we were able to systemically embed referrals at a geriatric outreach clinic in Sandwich Peninsula. And in 2020, we were able to embed in a second in Victoria. And in 2024, we were able to embed at a medical clinic. So we only have 3 embedded sites in British Columbia right now, but we're absolutely thrilled. And the future is I think, going to be a lot brighter. So what we learned from our PDS cycles, and you can go to the next slide, please, is that we've really been looking at who's making referrals, why are they doing it, how can we reach more healthcare providers, what changes can we make that will result in more referrals, and what are the structural barriers to embedding processes and structures in systems. Next slide, please. Here are our 4 referral pathways. So we have 2 systemic ways. One is through pathways, now BC Pathways. We've just recently become embedded in pathways as where physicians can directly refer into our organization, and we can have communication back and forth, which has been a really big win for us. We've been working towards this for a number of years. We have a number of small areas that have embedded clinical order set or EMR. We have our formal referral form, which of course can be done by fax and online. And then we still have our 10-second handoff, our Caregiver RX prescription pad. Next slide. So here's our evidence and impact. And I would say we've been working really hard at continuing to work on our evaluation framework. We started at a time where we were really focused on PDSA cycles. We had a very small amount of funding. This was done off the side of our desk. And so one of the really key things that I've been working on is a retrospective analysis. And one of the amazing things that has been emerging from our data is the impact of embedded sites. And so while embedded sites only represent about 12% of all of our referrals, they are the most stable and reliable. We have no referral gaps longer than 6 months with embedded sites, even with staff turnover. Non-embedded sites can sometimes show a 9 to 12 month gap, and really depends on our campaigns and our ongoing education. 38% of providers at embedded sites refer more than once a year versus 12% elsewhere. And 72% of referrals include our formal social prescribing approach consent form versus 49% in non-embedded sites. So this is like really incredible emerging data that's starting to come out after 10 years. We've engaged over 60 communities across the province. I know it seems small that we only have 240 annual caregiver referrals, but that's a 131% increase from 2016. So it's huge for us. And over the last 8 years, we've done 1,300 healthcare engagements, and that's everything from meetings and presentations. We have our change packages. We've got lots of great tools, which we're happy to share. Next slide. So what's next and why we're excited? Looking ahead, our focus is really going to continue with our stronger national connections. It's been really exciting to work with our other provincial caregiver support organizations for us to share, collaborate, learn from each other. We have common outcomes now in social prescribing that are caregiver focused, which we're really excited about. We're expanding regionally and with diverse communities. We're hiring our very first Indigenous liaison in the next couple of weeks. we're looking at these unified caregiver referral pathways, which are really exciting. And we're really deepening our primary care and health authority integration. So we have an upcoming caregiver-focused social prescribing shared care project with the Sunshine Coast, as well as some really amazing work with Providence Health that's starting to emerge. So the energy across Canada right now is incredible. We know that caregivers are a critical social infrastructure of our healthcare system, and we are really excited about the future to be able to support them earlier, more equitably, and more meaningfully. Thank you very much.
Awesome. Thank you so much, Wendy. There's, a lot of exciting work happening with caregivers in BC. I think Grace is back with us, so we'll switch back to Grace, and hopefully we don't have any more technical difficulties. So if we can just go back. Perfect. There we go.
Yeah, sorry about that, everybody. So I'm on Shreya's computer now, and so I think we should be good. So I was talking about the scaling and spreading at the health system side in British Columbia. And so what we wanted to do was embed the social prescribing scheme in the systems in the different health authorities, recognizing that each system is a little bit different, but utilizing what we've learned from the Fraser Health experience and sharing some of the tools and processes that we've developed. And so at the provincial level, we will have a provincial implementation and evaluation steering team, and that will be led by United Way, Ministry of Health representative from government, the regional health authorities, as well as academic leads who have been really helpful in implementing a implementation science approach in the way we're going to be doing this work, as well as those with lived experience in the community, providing us with community advisory representatives. And then at the regional level, within each of the local health authorities, we'll have the teams with the local United Way community specialists that I spoke about in the first slide, as well as a senior advisory group on equity, ensuring that we have equity in everything that we do and to ensure reach for all of our vulnerable older adults. And then we're going to support the local community connectors and the service providers through their community of practice. So that will be a regional team that's going to be very focused on tailoring the program according to the community and the health authority in each of the health authorities. And then finally, we'll be doing a thorough evaluation, again, using implementation science approach with looking at enablers and barriers at the health systems level, what allowed us to be able to make an impact and embed the social prescribing in the system, as well as at the personal level. And we will be using validated tools, as well as focus groups and interviews and surveys to look at, did the social prescribing scheme impact their social isolation and loneliness, their mood, their general health, their frailty level. And so we'll be using tools that will actually reflect the health of the individual and making an impact for the older adults that are serviced by our community connectors. And with the hope that we will be able to influence policy for sustainment of our system level intervention in British Columbia. And I'll go to the next slide, and thank you all for your attention. Over to you, Beth.
Awesome. Thank you so much, Grace. I think we do have time actually for probably one or two questions. And so if you're able, if you have a question for Grace or Wendy or Judy, if you can put them in the Q&A and we'll take two questions. So I'll just pause for a second so that people can, or in the chat, I can also monitor the chat if that's quicker. We'll see if any come through. Judy, I know there was a lot. Oh, there's an open question. So somebody asked, how do you become a link worker in Canada? So I don't know if anyone wants to answer that question. Any of our panelists?
I can speak for British Columbia, if that helps. Can you hear me okay?
Yeah, go ahead, Grace.
Yeah, so in British Columbia, we have local nonprofit organizations that hold the position of the link worker, and they are funded through United Way from the government. And so the local community organization would apply for a grant to be able to hire and manage that role. And so you would apply. You could go to the United Way website and see if there are applications or if there's a call for link workers or community connectors in different communities, or you can just look at the local organizations and see if if they have social prescribing schemes. But usually it's by knowing the community, knowing the local organizations, I think would be the best way to find out whether there's an opening. And then United Way, of course, would be another site as well.
I can add to that if you will. So I think there's a lot of diversity across the country in terms of the roles and competencies among the link workers and what we're all looking for in Newfoundland. I mean, they tend to be individuals with, you know, some post-secondary education. Ours are very diverse. I mean, one of our link workers has a kinesiology background and has a really good understanding around, you know, coaching, physical activity, motivational interviewing. Another one of our link workers is actually a registered social worker. So there's an extreme amount of diversity. I think the biggest, most important values are, as Grace said, the strong understanding of the community and the resources, motivational interviewing skills, absolutely. In our project, because we're focusing on older adults, we want folks who have a good understanding of the issues facing older adults. So, and of course, because in Newfoundland, we're also embedded in the healthcare teams, we want them to understand the health system. So, you know, that they are part of the team. So it's really important that they understand how that team works. And when they come to us, then we also offer significant amount of orientation and training to them. And we use the Canadian Institute of Social Prescribing's competency framework to really standardize that training.
Awesome. Thank you both so much for sharing your thoughts on that. So I'm going to move on to the next part of our agenda now. We have two more awards. So the first one is our Social Prescribing Researcher or Research Team Award, and this honors a researcher or research team that's made significant contributions to the evidence and knowledge base of social prescribing through innovative and impactful research. And so our first award recipient in this area is Hani Rook-E Kamar, and advanced social prescribing through a powerful combination of research, advocacy, and community leadership. Her scoping review with McGill University highlighted the importance of non-medical supports for older adults, while her work as founder and executive director of the Canadian Advisory of Women Immigrants has strengthened social connection and access to culturally safe resources for immigrant and refugee women. She brings this impact to global platforms as well through UNICEF and Can Watch, championing equitable, holistic approaches that bridge medical care with the social determinants of health. So congratulations, Hani. And our second recipient in this category goes to the Social Prescription Collaborative, Elaine Adams and Catherine Paquette. And this collaborative has spent 4 years building a rich interdisciplinary research community that is advancing the implementation of social prescribing across Quebec and beyond. Through co-leadership by Dr. Adams and Catherine Paquette, the team has engaged more than 20 student researchers, led over 25 outreach sessions, and developed participatory co-design approaches that reflect the complexity of the Quebec landscape. Their innovative work, ranging from ontologies that match social needs with services to studies on social assessment, community barriers, and inclusive co-design, they've generated evidence that is now shaping practice, advocacy, and system-level change. Congratulations to our research award winners. And our final awards are the Social Prescribing Changemaker Awards. And so these awards are for folks that are really leading social prescribing work across their community. And our first recipient in this category is Althea Martin Risden from the Rexdale Community Health Center. Althea is a community leader whose work embodies the heart of system-shifting social prescribing. Through her role at Rexdale Community Health Center, she has championed culturally grounded, person-centered approaches that build trust, strengthen belonging, and connect individuals to supports that improve well-being. Her leadership, advocacy, and deep community relationships have made her a driving force for change, uplifting voices, reducing barriers, and advancing more equitable pathways to care. Congratulations, Althea. And our final award of the day goes to the ParkRx BC Park Foundation, Ode to Wonder, and the Vancouver Art Gallery. So the BC Park Foundation, in collaboration with Ode to Wonder and the Vancouver Art Gallery, has transformed how nature, creativity, and cultural experiences are integrated into well-being. Through innovative nature prescription approaches and partnerships that connect people to the outdoors, the arts, and community spaces, they have expanded the possibilities of non-medical supports across Canada. Their leadership has inspired national momentum and demonstrated how cross-sector collaboration can meaningfully improve health, belonging, and quality of life. So heartfelt congratulations to all of our nominees and recipients. I think there was over 100 nominations across those categories. So it really goes to show the growth and momentum that there is around social prescribing across the country. And yeah, really just inspiring work and helping to build a more connected, compassionate, and equitable Canada. So our last panelist, I'm going to pass it over to Charlotte to share about the current state of social prescribing in the UK, the learnings, and the direction forward. So over to you, Charlotte.
Thank you. I'm hoping that you can hear me okay and see me okay. Brilliant. Thank you, Beth. So pleased to be here today and to hear everybody else's presentations and to say a huge congratulations to all of the award winners, such amazing projects. So I'm Charlotte Osborne Ford. I'm the Chief Executive at the National Academy for Social Prescribing in the UK. And I'm going to give you an overview of developments in the UK. I was able to join you last year at your conference. So some of you may have seen me before and heard me talking about what's been happening in England. So hopefully this will be a useful update. Next slide, please. So the National Academy for Social Prescribing, we think of ourselves as sisters to the Canadian Institute for Social Prescribing. We really do have a very similar setup, function and priorities. We are a charity and we're lucky to be funded at the moment by the UK government. And our functions are below. We connect up the system, we drive innovation, we try to secure more investment into social prescribing, particularly into community assets. We drive forward the evidence and not just academic research, but community-based evidence and data. And then we raise awareness, particularly to increase equity and inclusion and help more people understand social prescribing and what might be available. And around 168,000 people accessed our resources over the last year through our website. So we're getting increasing reach. Next slide, please. So social prescribing became NHS policy in 2019 in England. And I really enjoyed hearing from the other speaker today about how it took 10 years to make progress. It took at least 20 years in England to make that progress. And so it really does take time and keep going is message number one. So that happened in 2019 and social prescribing became part of the primary care GP contract. And what that means is every primary care centre, every GP practice must offer social prescribing in some way. And a funding mechanism was deployed from government across the country, which would enable GPs, primary care doctors, to employ and fund the costs of employing social prescribing link workers. We have NHS and National Health Service guidance and a competency framework. And of course, it's very similar to the competency framework for link workers that you have in Canada. Some research has been done around the rollout of social prescribing over those 5 years, and there were 9.4 million consultations in primary care that involved social prescribing in one form or another over that 5-year period. So what that tells us is huge demand from the public and from doctors for social prescribing. And our own study shows around 22% of the public in England now understand the term, and 97% of GPs are favourable towards it, which is a huge change than 10 years ago, when many doctors would say, well, what is it to do with us, and why do we need to do this? Next slide, please. So one of the key tactics that we've used in England is to get national media on board to raise awareness of social prescribing, and particularly to share the stories from people that have benefited. And we have so many people who have benefited and want to share their stories. And very often what they want to share is that social prescribing saved their life. And the two examples in the corner there are just so typical, where people feel that it's the only thing that's made a difference because it's helped them navigate lots of other complicated and complementary services. But most importantly, that phrase that was used earlier, motivational interviewing, coaching, it really provides that holistic support to help people think about what matters most to them, and really to map through what can help and help them access those things that can help. And so we work very hard with the media to try and showcase social prescribing. And that's ultimately because we want funders, commissioners, and government to recognise that it isn't just a little intervention that's happening organically, but it's a really important mechanism that should be valued and scaled. Next slide, please. So one of the most important challenges that we had in England over the last, 10 years really, is to show the healthcare system that social prescribing isn't just good for patients, but actually it's cost effective, and that it should receive public health investment. And so the Academy, we produced this report last year. It's not academic research, but what it is system evaluations and data from within different health systems, sometimes large health systems, integrated care boards, and sometimes just small networks of primary care services. And what we saw when those organisations shared their data with us is that there were typically reductions in doctor's appointments, in hospital admissions, and in emergency room visits. And then often we were able to put costs onto those and demonstrate reduced demand and reduced costs. And this report has been really helpful for us in advocating for increased funding into social prescribing. Next slide, please. Alongside that, two important pieces of academic research from England this year. This one was funded by the National Institute for Health and Care Research, which is a government body funding research. And it's the first large-scale study of social prescribing. It looked at 4 million patient records, not 4 million people that had had social prescribing, but it looked at their records. And what it found was, for patients in a GP practice, a doctor's surgery that had social prescribing, there was direct correlation between those patients being more confident managing their long-term conditions and their experience of their general practice. So this was very robust evidence, and for the first time looked at social prescribing at scale. Next one, please. And the other really important research is from our partners at University College London, Professor Daisy Fancourt, who is one of the world's leader in social prescribing evidence and research, particularly from an epidemiology perspective. And this piece of research, which was published in The Lancet, looked at the scale of social prescribing in general practice. And it particularly, you see that figure of 9.4 million GP consultations, but what the research found is that there are at least 1 million referrals to link workers directly from GPs to link workers every year. Next one, please. A lot of our work at the Academy is still trying to embed social prescribing. So when I give these presentations in other countries people say it's amazing how much progress you've made and everything's so amazing in England, but we are a country with a health system in crisis, and we have to constantly raise the awareness of social prescribing and make sure that we don't see social prescribing fall backwards or reductions in link worker numbers. And so we have had social prescribing mentioned in some other government departments this year, which is really positive, particularly thinking about keeping people in employment with health conditions and thinking about the environmental improvement plan and nature. But social prescribing hasn't featured heavily in the latest 10-year health plan. And so one of our priorities is to really make sure that social prescribing does remain at the forefront of preventative health. Next one, please. And social prescribing is a hugely growing movement. It's amazing to hear everything that's progressing in Canada, and Canada certainly is at the real forefront, but there are lots of other countries doing this and adopting this. My colleague was in Lithuania last week, and the health minister there announced that social prescribing will be in health policy. And of course, we've got the amazing conference in Australia next week that I know some of you are able to attend. So it really is taking off around the world. And what opportunities that offers is real peer support from each other's country. So I'm struck by what I've heard today. We have so much in common, even though we're so many miles apart. Almost everything that you've talked about today and shared could have been discussed and shared in England. It really is remarkable, and I think that's such a strength of social prescribing, that there is so much in common, both in terms of the need, the evidence, the outcome, and really the focus on people rather than patients and what can support them and what they can do for their health. Next slide, please. And just to say, it's brilliant that that was recognised in the recent World Health Organization report on social connection. And I think this is one of the first times we've seen sort of global recognition. So do check out that particular report, which is about healthy societies and from loneliness to social connection. It explicitly mentions social prescribing as a community strategy that health systems should take. And I think that's my last slide. Thank you. Do follow us on social media if you want the latest updates from England.
Awesome. Thank you so much, Charlotte. I can vouch for the newsletter that NASP sends out. Often has some really, really great resources and applicable in our Canadian context as well. I think we have time for a few questions if people wanted to put them in the Q&A or the chat. I'm sure Charlotte would be able to answer a few questions before we wrap things up for the day. We'll just wait a second to see if any questions come in here. So Linda's asking, would you be able to share key strategies to involve general practitioners in the UK? I think that's something that we still are struggling with here in Canada.
It's something we hugely struggled with in England. So unfortunately, I can't necessarily give you a sort of a magic bullet answer to that one. And as I said, it took a very long time to embed this. What we would say is there's sort of two key elements. One is, of course, the evidence and research, because doctors are trained over many years to think about evidence, data, research, efficacy, and the higher the quality of research, the better. So that's why we spend a lot of time trying to get articles in the Lancet and in other medical journals, because we know it adds to the credibility. But ironically, the other side is very much seeing is believing. And I think a small number of senior GPs and politicians took the leap to put social prescribing into our health policy and to embed it, when many GPs were quite skeptical. But what often turned them around was a patient that they had had for a long time, who was really struggling, and who couldn't necessarily, they couldn't address all of their needs. And then they saw the patient flourish, doing something positive or having something addressed. They heard that that feedback. And that was what really made the difference, is having one of their patients go through it. So that's probably it in summary, robust clinical type evidence alongside genuine patient stories and people really being able to experience it.
Yeah, that's great. I think those are really, really important tips. Another question. There's someone here who mentions about trying to create a digital platform that connects millennial and Gen Z users to social prescriptions. So I think a lot of the work in Canada right now is focused on seniors. And so how can we develop more kind of intergenerational approaches to social prescribing to make it more accessible to other areas of the population?
Interesting. In England, we have a real proliferation of digital solutions. And what was interesting in our 10-year plan for health is the only mention of social prescribing is linked to digital, where it talks about the need for an app for the health service, and for that app to include digital social prescribing to connect people directly either to digital solutions or digitally through to community solutions. So that isn't a real growing area, but it's very important that we remember the core principles of social prescribing are about that personal relationship. And I think the digital side can be a good tool and can reach more people, but not at the expense of the sort of relational elements. In terms of the intergenerational, I think initially it was mostly older people that were referred to social prescribing in England too. But we have particular issues with younger people's mental health and with people not able to work due to poor health. So we're seeing a real push towards engaging those sorts of demographics. And as part of that, thinking more creatively about what might be available, both in the community and again, integrated with digital. So I think we've really seen that demographic catch up, and they can benefit just as much from social prescribing as socially isolated older people.
Awesome. Thank you. I don't see any other questions. There was a question from Julia in the chat about getting the work going in Calgary, which is actually in my area of the country. So Julia, I don't have a way to put my email address in the chat. For some reason, I don't have that ability, but yeah, I can connect with you. I'd love to chat more. We have a really great social prescribing program happening in Calgary already, so would love to get you connected into that. Awesome. So thank you so much, Charlotte, for that presentation. It's always great to hear about things that are happening in the UK. I think we very much look to the UK as a model for implementing our own social prescribing programs here in Canada. So I think we're coming to the end of our agenda. I think we're actually a little bit ahead of time, so that's really great. Just wanted to note again that recording and slides will be shared via email in the next few days. More information can always be found on the CISP website as well. There is a survey that's going to be shared at the end of the webinar as well. So please take a few minutes to give your insights on how this webinar went. And last but not least, I'm also happy to share that the Canadian Institute for Social Prescribing is launching an explainer video to introduce social prescribing. And this video can be used as an introductory resource, an advocacy tool for your partners and stakeholders to build social prescribing collaborations in your area of work. And so I think Nicole is going to play the video now, so please stick around for the launch of the video as well.
What is social prescribing? What impacts our health the most? It's our everyday lives, our homes, jobs, relationships, and community. Factors such as safe housing, financial stability, meaningful relationships, and social connections play a significant role in our overall well-being. That's why we need to support health beyond the walls of the healthcare system. Social prescribing does just that by providing individuals with supported connections to community programs and resources that meet their individual needs and interests. It offers a person-centered approach to care, shifting the focus from what's the matter with you to what matters to you. Through social prescribing, individuals play an active role in planning their care. They are supported in accessing community services such as peer support groups, fitness programs, housing resources, or arts and culture activities. It's about linking health and community to address the full picture of someone's well-being. By working together to harness the strengths within our communities, healthcare providers and community organizations can create a more sustainable and responsive health system that truly supports the whole person. With social prescribing, we can make a meaningful shift in how we care for people.
Thank you, everyone. Have a great day.